Hello, this is Patricia Nill. I will be completing a review summary on Chapter 12, Schizophrenia Spectrum Disorders. There are 7 objectives in this chapter that you want to think about. Objectives 1 and 2 go over, you want to think of a few questions. So how do you think schizophrenia presents initially in patients? What do you predict are the most common comorbidities in persons with schizophrenia? And what is your rationale for such predictions? When you think about Objective 3, you want to look at how most people now have had contact with someone, students for example, who has either had schizophrenia or a schizophrenia spectrum disorder or have seen. How would you anticipate the effects of both the disorder and its treatment on the individual's quality of life? When you look at Objectives 4, 6, and 7, you want to think about how the outcome should focus on illness management, coping, maximizing one's quality of life, and that outcomes should be consistent with a recovery model, as opposed to focusing on controlling symptoms and adapting to disability. What do you think this means in terms of your own approach to working with a patient experiencing psychotic symptoms? When you look at Objective 5, you want to think about reflecting on how knowledge of these might affect the content of a teaching plan for a patient taking one of these drugs. As you start going through PowerPoints 1 through 8, you want to start thinking about the clinical picture, the epidemiology, and the comorbidities. So for example, you want to think about the key point, how schizophrenia spectrum disorders are biological disorders of the brain. You want to think about the DSM box, the Diagnostic Statistical Manual, which is how patients get diagnosed, and this is the diagnostic criteria for schizophrenia. If you look in your book on page 193, and you can kind of follow along with me, you can go over the criteria for schizophrenia. So there's letters A through F. If you start with letter A, you want to make sure that the patient has 2 or more of the following that are each present for a significant portion of time during a 1-month period or less if successfully treated. At least one of these must be 1, 2, or 3, meaning 1 delusions, 2 hallucinations, or 3 disorganized speech. Then you want to look at number 4 and 5, which are grossly disorganized or catatonic behavior, and we showed pictures in class, and negative symptoms, which can be diminished emotional expression or avolition. If you look at B, it goes over the time since the onset of the disturbance, the level of functioning. C goes over the continuous signs of the disturbance that are persistent for at least 6 months. And then the 6-month period must include at least 1 month of the symptoms from criteria A that we had just spoke about, meaning that you have to have 1, 2, or 3. And then D goes over schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out. E goes over the disturbance is not contributed to the function effects of the substance like drug abuse or medications. And F goes over if there's a history of autism spectrum disorder or a communication disorder. As you continue, you want to think about how comorbid anxiety and depression must be identified and treated to reduce the potential for suicide and substance abuse, non-adherence, and relapse. Helping the patient to learn to regulate emotions such as stress management techniques, self-nurturance, instilling hope, and participating in rewarding activities is very important. You want to also look at the key point thinking about substance use disorders, how they affect the majority of people with schizophrenia and can intensify symptoms and cause relapse. How prevention, screening, and treatment of substance use disorders are very important. You also want to think about the high percentage of substance abuse comorbidities in this population. As you continue going through your slides, and you get to slides 9 through to 9, this is going to look at the biological factors, psychological, environmental. So the key point is that schizophrenia is a group of related disorders with overlapping symptoms and treatments but varying etiologies. Another key point is that neurochemical, genetic, and neuroanatomical findings help explain the symptoms of schizophrenia. No one theory accounts fully for the complexities of schizophrenia. Another key point is psychotic symptoms are often more pronounced and obvious than symptoms of other disorders, making schizophrenia more apparent to others and increasing the stigma. As you're thinking about schizophrenia, you'd like to think about the diathesis stress model of schizophrenia. This model will help you understand the cause or the complex etiologic theory. So you want to think about two questions that you want to make sure that you have clarified. So question 1, what two types of conditions are generally thought to combine to cause schizophrenia? So your answer should be, the scientific consensus is that the schizophrenia occurs when multiple inherited gene abnormalities combine with non-genetic factors such as viral infections, birth injuries, environmental stressors, and prenatal malnutrition. Furthermore, what alterations are they typically assumed to make within the brain? That's your question 2. And your answer should be, according to this theory, this combination usually causes schizophrenia by affecting the brain in one of the following ways: either by altering the structures of the brain, or affecting the brain's neurotransmitter systems, and or injuring the brain directly. As you continue and you go to slides 12, and you can go all the way up until slides 34, this will go over the application of the nursing process, starting with assessment and prodromal phase, which is the early phase. So as you're following along in your book, turn to page 197 and think about, can schizophrenia be prevented? So as you're thinking about, can it be prevented? They go over malnutrition, infection, tobacco use during pregnancy, marijuana, and drug use. In vulnerable people, how it increases the risk of developing schizophrenia. The primary prevention aims at avoiding these factors, but they go over the risk factors that they can be, not all of them can be avoided. So they want you to think about avoiding triggers such as environmental stressors, interventions to promote resiliency and coping in children and families. And then there's two additional options that they want you to think about, such as early treatment with antipsychotic meds and or supplemental essential fatty acids. And these assessment tools identify the early symptoms or prodromal factors. As you're continuing on page 197 and you go over the 4 main symptoms of schizophrenia, it looks at the positive symptoms, which are hallucinations, delusions, disorganized speech, and bizarre behavior, as opposed to negative symptoms, which are blunted affect, poverty of thought, loss of motivation, avolition, inability to experience pleasure or joy, and hedonia. Cognitive symptoms such as inattention, early distraction, impaired memory, poor problem-solving skills, poor decision-making skills, biological thinking, impaired judgment. Affective symptoms, dysphoria, suicide, hopelessness. All of these dimensions alter a patient's ability to possibly work, relationships, self-care, social functioning, and quality of life. As you continue and you move to page 198 and you go over the types of delusions on table 12.1, this goes over persecutory, referential, grandiose, somatic, control, nihilistic. So all of these, the key point is that positive symptoms of schizophrenia such as hallucinations, delusions, associative looseness are easier to recognize and respond to the best to the antipsychotic drug therapy. As you're thinking about this, think about, how do psychiatrists decide what side effects outweigh the consequences of a relapse? So think about that question as you're going through these chapters. As you continue all the way up until page 201, it kind of starts going over the consideration in the culture box It kind of talks about the stigma of schizophrenia in the Chinese family or population. So we said we would integrate culture a little bit in each. So you can read that and just kind of see for Chinese culture what their considerations are. This goes over a scenario with Mr. and Mrs. Chow and how they learned that their mom had died of pneumonia, but that she may have had maybe a history of something else going on, maybe a comorbidity. And then they talk about how the staff talked about treatment for heart disease or diabetes, and that he did not feel shame that others would help, and that he would improve the illness and reduce their guilt so that they met a healer. And the key to the whole thing is about resources, that they found resources that would help them and that worked for them. They thought the healer would work for their group. So the key to all of that is not to memorize this box. The key is that whenever you have a patient, regardless of what the culture is, that you find out what their views of their own culture is, because it may not be textbook, right? So just remember that, keep that in mind. Okay, we're not going to have them all memorized. The other key point is that negative symptoms of schizophrenia, reduction in affect, social withdrawal and dysfunction, lack of motivation, inability to experience pleasure, respond less well to antipsychotic therapy and can be more debilitating. Psychosocial interventions such as support groups improve negative symptoms. So think about our groups that we're going to be seeing throughout the semester. Also, another key point, so cognitive impairment varies and tends to respond poorly to medication. It warrants active interventions such as cognitive remediation therapy, which teaches recall, attention, and other skills to increase the patient's ability to function and maximize his or her ultimate quality of life. Another key point is that you want to think about is that it is important for nurses to assess and support functions such as hygiene, self-care, nutrition, rest, and assure that a therapeutic milieu environment, such as reducing undue stimuli on the unit, is key. Okay? So you can continue. Basically what I just said was in all of these slides. And then I want you to just go up to slide 35. So slides 35 to 41 are going to go over diagnosis, outcomes, identification, right? The nursing process. Okay. So if you look in your book on page 201 and you look at table 12-2, this goes over the signs and symptoms of the nursing diagnosis for schizophrenia. So what you want to look at are positive symptoms. They're hearing voices, hallucinations, or auditory, right? Like we did in our group. Hears voices telling him or her to hurt somebody, or delusions, right? Disturbed belief system. So you can kind of, whatever your patient is exhibiting, you can look in your book and see what your individual patient would be presenting with and what diagnosis based on your data. But also shows loose association, conversation is derailed. They go over negative symptoms where the patient is withdrawn, maybe social isolation. Remember, it has to be a 3-part diagnosis, right? They're only having the first part according to NANDA, right? Expresses feelings, talks maybe about themselves as bad or no good, and shows lack of motivation. So this just gives you some examples of what diagnoses you could use. So if you have a patient with schizophrenia, you can refer back to this. The key point is that some nursing diagnoses include disturbed sensory perception, impaired communication, ineffective coping, impaired thought process, risk for self-directed or other directed violence, and impaired family coping. You also want to think about how outcomes are chosen based on the phase of the disorder and the patient's individual symptoms or needs, so their strengths, their values, their level of functioning. Short-term and intermediate indicators are also developed to better track the incremental progress typical of schizophrenia. If you turn to page 202 and you look at box 12.2, this goes over relapse prevention. So this is a case study in a nursing care plan. So if this goes through letters A through J, they go about talking about early warning signs of relapse, sleep disturbances, troubling thoughts, goes over let your treatment team know right away if you begin to have symptoms of relapse. C, find people you trust. Remember, trust and listening to your patient is the key. D, remember that relapse is part of the illness, not a sign of failure. E is develop a relapse prevention plan, not using drugs or alcohol. F, participate in family group. Individual therapy is needed by, maybe the staff is going to give you some resources. G, learn new ways to act and new coping skills to help handle family, work, and other stressors. H, have a written plan of how to cope with these stressful times. I, adhere to treatment. And then that goes over, making sure that you're not stopping your medication. Remember that you're keeping the side effects. You let them know, you talk about them, that you are not engaging in struggles, that you're staying in your treatment, that you're sharing your concerns about your troubling side effects so they can help you, such as weight gain or feeling funny, right? And then maybe J, avoiding alcohol and or drugs. Okay. If you go to page 205 in your textbook and you look at table 12-3 on the bottom, additional nursing interventions for the person experiencing psychosis. It goes over poor hygiene, how this contributes. It goes over resistance to treatment, such as, side effects, stigma, inconvenience, or checking or palming their meds. This is a big one when you do med observations. Please make sure that you're looking at the hands and looking in the mouth. And all that good stuff, because you don't want someone storing their medications. If you turn to page 209, box 12-3, and I'm just following along with you, goes over helping patients who are experiencing hallucinations. It starts with nursing care, how you got to watch the patient for hallucinating cues, such as their eyes. Ask about the content of the hallucinations. Are they commanding them to do something? Avoid referring to hallucinations as they are real. Do not ask what the voice is saying to you. Ask, what are you hearing? Be alert to signs of anxiety. Do not negate the patient's experience. Focus on reality-based, the here and now. Address any underlying emotion. Promote and guide reality testing. As the patient begins to develop insight, guide him to interpret hallucinations as a symptom of his illness. You want to teach the patient to manage stress and stimulation. Avoid overly loud or stressful places. Avoid negative, critical people. Learn assertive communication. When stressed, slow and deep breathing. Use other sounds to complete with hallucinations, such as we usually provide headphones. Sometimes they sing, sometimes just talking with others in a group can drown them out. Find out what is and isn't real, called promoting reality testing. Engage in activity to take their mind off, such as walking, cleaning, taking a relaxing shower. Again, playing music is a big one. Talking, making contact with others, and develop a plan to cope with their hallucinations. Then if you look on page 209 and you look at box 12.4, helping patients who are experiencing delusions, notice number 1 is build trust, being open, honest, genuine, reliable. Respond to the suspicion in a matter-of-fact, supportive, and calm manner. Ask the patient to describe his beliefs. Never debate the delusional content. Validate if part of the delusion is real. Focus on the feelings of the themes of the delusion. Use reality-based interventions that help meet underlying needs. Acknowledge that while the belief seems very real to the patient, that they can make things seem true even though they are not. Introducing the indirectly can make it less confrontational. Do not dwell on the delusion. help the patient to identify triggers for delusions, and promote reality testing by questionable beliefs. If you go to page 210 and you look at patient and family teaching of schizophrenia, you want to have regular content with supportive individuals, keep healthy and stay in balance, taking care of the diet, minimize use of tobacco and caffeine, maintain a stable weight and work to lose the weight, maintain a regular sleep pattern, keep active with hobbies, nurture yourself and practice stress reduction activities daily, join a support group such as NAMI.org, read books, and they give some examples of books that they can read. Access trusted websites and online videos, including Living with Schizophrenia, I Am Not Sick, I Don't Need Help, the National Alliance on Mental Illness, that's another good one. Schizophrenia.com is a good one. They're all good. National Institute of Mental Health, Out of the Shadow, Minds on the Edge, Schizophrenia Related Disorders Alliance of America, which is a support organization. If you go to PowerPoint slides 42 to 51, this goes over psychobiological interventions. If you look on page 211 and you look at table 12-4, long-acting injectables, antipsychotics, you can look at the first generation antipsychotics such as haloperidol. You can look at the second generation antipsychotics like olanzapine. You can look at, so the Sustenna is another one that you will be giving as well. You'll see all of these in the hospital setting: risperidone, Risperdal, ariprazole. So all these you'll see. Just take a look at the names and different nursing considerations. As what's really important is remembering to monitor the patient for excess sedation, such as like with the olanzapine. The rest of them just go over how you're giving it with the Z-Track method to keep the medication in, and that is because it's an IM injection, and that's just how you hold it, right? And we can go over how you give a Z-Track injection to keep the medication in the muscle, right? Also, so that's all that is going over as far as the injectable antipsychotics. And then if you go over page 212 and you look at table 12-5, this one goes over antipsychotic drugs, the classification, and the relative side effect profile. So again, first generation conventional antipsychotics, typical, right? They go over low potency, medium potency, high potency. What you really want to be looking at here, extrapyramidal effects is a big one you want to look at. Will my patient get sedated? Orthostatic hypotension, so when my patient stands, they don't fall on the floor. And anticholinergic effects. Some patients we really need to focus on why don't they want to take their meds, like maybe weight gain, diabetes. And then if you look at second generation, the atypical antipsychotics, they have them all listed here, and they go over the same things. So you just want to take a peek at that. Then you want to look at page 213, figure 12-2. We've gone over this in class and in clinical as well. This goes over the abnormal involuntary movement scale, the AIMS. It was developed by the National Institute of Mental Health. It's to identify and track involuntary movements. Using the AIMS is a key nursing role in treating this population. So you want to just take a peek at that and make sure that you're knowing that you're looking for the EPS. The tardive dyskinesia is what we're looking for, the involuntary movements that are related to the antipsychotic medications. More prevalent in the first generation. The third generation has less risk of EPS, right? If you look on page 215 and you look at table 12-6, the side effects of antipsychotic medication, this is an evidence-based practice box considering culture as well. So for this one, you want to look at the side effects, dry mouth, urinary retention and hesitancy, constipation, blurred vision, dry eyes, sexual dysfunction, anticholinergic toxicity. Make sure you're looking because reduced or absent peristalsis, tachycardia, right, with delirium, Pseudoparkinsonism, right? The mask-like face, the stiff and stooped posture, shuffling gait, you may see this as well. Acute dystonic reactions, so acute painful contractions of the tongue, face, neck, and back. Usually occurs in the tongue and the jaw first. Spasm of the muscles causing backward aching of the head or arching of the head and the spine. Eyes rolling back and laryngeal dystonia. Think about their airway, right? Akathisia, so the motor restlessness, the pacing, unable to stand or sit still in one location. And tardive dyskinesia, the face protruding, or the tongue, the blowing, the smacking, the licking, the facial distortion of the limbs. Think about the trunk, the neck, and the shoulder movements, the hip jerks, and the rocking or the twisting pelvic thrusts. Hypotension or orthostatic postural hypotension, when they're standing up, the systolic rises, systolic decreases, and the pulse will increase. As you're looking in the book, you want to think about a couple of key points. If you go to page 216, this actually continues the side effects of the antipsychotics, so we'll just continue that. Remember agranulocytosis, remember the jaundice, and a big one, neuroleptic malignant syndrome, so remember the NMS. Rare but dangerous, severe muscle rigidity, high temperature, hyperexia, greater than 103, delirium, stupor, coma, and metabolic syndrome. So as far as a key point, think about the interventions for people with schizophrenia. Focus on trust building and therapeutic communication, support, education, and assistance to assure adequate self-care, malnutrition, and sleep. Promoting independence, teaching and motivating effective stress management, teaching social and communication skills, and promoting interaction, psychoeducation, milieu management, and ongoing risk. Assessment and response. Just a couple of key things. Remember, with antipsychotics, we have first generation, which started in 1950s, second generation, 1990s, and third generation, which is the newest, little EPS and little tardive dyskinesia, but still exists, but the least amount. An example is aripiprazole, and Abilify is the other name for it, right? So we have generic and trade. Another key thing, as far as antipsychotic medications are essential in patients with schizophrenia. You want to think about nurses must understand the properties, desired and undesired effects, and dosages of first and second generation antipsychotics and other medications used. You also want to think about the side effects can be very distressing to a patient, and some are potentially fatal. So this concludes everything that I wanted to tell you about this chapter as far as the key points. Okay, so thank you.